Okay. Good evening. Good evening. Welcome back. See, our topic of discussion today is renal and hepatic dose adjustments. So this we can consider one of the most, clinically important topic in our pharmacy practice. And why? Because we need to understand the status of renal and hepat before dispensing or advising any type of the drugs, right? So many drugs, fail because it is not because of they are ineffective directly, but we can say it is because they are not, dosed correctly according to their own organ function, patient's own organ functions. That's the reason we need to calculate accordingly. Okay. Renal and hepatic dose adjustment is, we can consider it is not an optional knowledge, right? It is mandatory. Okay. This is mandatory and this is not optional for our pharmacy practice. This topic directly affects your overall patient safety, your adverse drug reaction, its prevention, and the treatment success, I can say. Just give me a minute, guys. Just a minute. Okay, so yes, it directly affects overall patient safety and the ADR prevention and the treatment success, right? So this topic we cannot consider optional. Okay, and when we talk about precision, right? Precision dose calculation, that means directly individualizing the therapy. So what do you mean by individualizing therapy? Broad way. We need to understand that we need to first identify what is the renal function of the particular patient. Was it like, is it normal or no, right? And we also need to understand the hepat, right? So before going towards anything, any dispensing and the prescribing things. Oh, also we can skip simple suggestion to require the monitoring of renal and hepatic things, right? In fact, if you want to monitor your treatment efficacy, you need these things again simultaneously. So in every aspect, you need this. Now, why we will start with why only? Why this renal and hepat two only? See, we have multiple organs, and every each of the organ has immense role to play. But when it comes to hepat, of course, the first pass metabolism with all of your oral medication happens with the this hepatic things, right? Hepatic system. So that's the reason we need to understand if the patient is having any type of issue with the liver metabolism, you will not achieve your appropriate therapy. You will end up having toxicity or some side effects, right? So we need to understand for that the hepatic dose calculation and adjustment. And you also know that 90% of the drugs are being excreted by the renal route, okay, kidney route. So we need to understand the renal function for that reason, so we can eliminate some of the some accumulation or toxicity later. So when we talk about precision dose calculation, meaning individualizing therapy, that is, not blinding following the standard doses, whatever it is listed in our algorithm or whatever is available in our inventory. We cannot do that, right? When we talk about precision therapy, precision dose calculation, when we talk about individualized treatment. So, in the real hospital practice, I can say most of the admitted patients, have some degree of this renal or hepatic dysfunction. Okay. I'm talking about the patient admitted in the hospitals. Okay. So, most of the admitted patients have some of the degree of this renal or hepatic dysfunction. Especially, we can consider elderly. Okay. Especially elderly population, intensive care unit, sepsis. I can consider diabetes also here, cancer patient also here. All those population have some degree of this renal hepat dysfunction. And a pharmacist is the one, who understands the dose adjustment which is required in the renal and hepatic dysfunction cases. And that becomes clinically very, very, I can say necessary, right? It is a necessity. And yeah, that is what you need to learn today. So I hope this topic is making sense to you. And many of you might be also aware of this hepat and renal dose calculation, because it is not that new topic, of course, but many are failing. Okay, many are failing to adjust the doses, and that's what our objective is. So let's understand first why dose adjustment matters first of all. So you know what? Here you should you need to understand the pathophysiology behind this, right? So behind toxicity actually. So, see, drugs are eliminated mainly by the kidneys via urine, right? And it is metabolized by the liver via, some bile and metabolism process. We have multiple process in it. So, if this two organ fails, your drug clearance can decrease. Okay, your whole drug half life can increase. Your drug can be present in the body for more than expected time. That is what half life is increase means. Then what can else done? Yes, drug accumulates in the body. Plasma concentration can be, rise, because you will fix the standard intervals between two doses. But if the renal function is poor or hepatic dysfunction is there, already the previous dose will be there in the body and you are administering the second dose, so it will lead to the toxicity. Plasma concentration will increase more than expected values, and it can lead to directly the toxicity. So these things are very dangerous. So you need to understand. See, for an example, I can give you here some example also to understand. For an example, aminoglycosides. So aminoglycosides in the renal failure, you can just imagine that aminoglycosides are excreted from the kidney root. And if the patient is having renal failure thing and you are having the aminoglycosides in the prescription, what happens next? Of course, you will have acute kidney injury, plus you will be having some other effects as well associated with it, and that might cause some big problems like some hearing loss, and all the things are associated when we talk about practical things, right? For example, the next example I can give, that is metformin, simple drug. Metformin in again renal failure, you can understand, if you are advising metformin in the renal failure cases, of course you will end up with having lactic acidosis, right? Also, we have some other example like diazepam in liver failure, for example. So if the patient is having liver failure or any stage of fatty liver condition, and if they are taking diazepam, of course they will be having some risk over there over longer period of time. So those risk can be life threatening as well. Okay, some prolonged sedation and the coma like situation can also happen with this. Now this is drug induced, right? So that's the reason we need to understand how exactly hepat and renal is playing a big role in the dose calculation and how to exactly calculate it. Okay, so see, doctors may prescribe the correct drug, guys. Okay, but dose adjustment is the pharmacist clinical responsibility. So this is where I can say pharmacy is moving from theory to some life saving practice when it comes to dose calculation. So that's the reason why we are learning today. So we need to understand the clinical impact of this two organ dysfunction on drug metabolism and excretion. Renal and hepatic dysfunction causes the drug accumulation and toxicity, and yes, pharmacist ensures here the patient's safety. So let's start with the learning objectives so that it will be clear to you by the end of the session what you will be able to understand. So you need to understand, by the end of the session, you will be able to calculate this very important creatinine clearance. Okay, not just the formula memorization. Okay, because creatinine clearance has a very simple formula to calculate. Many of you might be already having idea how to calculate creatinine clearance, but we are not here to just memorize the formula, but we will understand what the number means for dosing here. I'm again repeating. We will understand here what the number creatinine clearance means for dosing. Also, by the end of this session, that will be our first learning objective. Second is you will be able to adjust the doses in the CKD patient. So that is extremely important. Okay, you should know how much to reduce and why. Okay, how much to reduce and why, not just the dose adjustment which is required. Dose adjustment you can simply do by some applying some formula which is already pre-existed and predefined, nothing to do with it. Okay, and easy to remember also in daily practice. But what is important is in which situation exactly you need to do this dose adjustment, why behind it. Okay, so that is extremely important. You should know how much to reduce and why it is important, not just only the dose adjustment required. Okay, that is our second learning objective. Third, we will focus on understanding this child pug. Now, you must be knowing that why this liver disease severity matters more than just your AST, ALT. I hope you have idea about AST, ALT, SGPT, SGOT and all. So these are the liver enzymes, right? And apart from that ratio, we need to understand that why this liver disease severity so much matters and how exactly we can calculate by using this child pug. Child pug has one formula, guys, for the hepatic dysfunction. Okay, I will let you know those are our third learning objective. And the fourth is, as usual, we will apply this learning into some real lab reports. Now, this is a little bit critical. So in real practice, you don't get, textbook questions, frankly. You get lab sheets in your hand. Okay, you get some progress notes, you get some medication charts. So we will see how exactly it looks like and how exactly we can solve it. So we will apply our learning from to this lab reports. Okay. So these are our learning objectives for the session today. I hope it is clear to you and making sense that what is coming in the session. That is extremely important before jumping into the PowerPoint, guys. Okay. Let's start with the very important comparison, renal versus hepatic elimination. Here you need to understand that drug behavior inside the body, how exactly drug is behaving into the body. Okay, you need to understand that water soluble drugs cannot cross the lipid membranes very easily. Okay, so that is what the excreted means. They will, becomes unchanged in the renal. And some lipophilic drug that crosses the membrane. Okay, so they need liver metabolism to become water soluble more. These two concepts you need to understand here. So you need to differentiate the drug clearance pathway based on its solubility and molecular property. Molecular property, that means whether it is whether it is water soluble or whether it is lipophilic drug, right? So renal, of course, water soluble drugs. Water soluble drugs cannot cross lipid membranes easily. Okay, so it is excreted unchanged via renal route. While lipophilic drug crosses the membranes, it needs liver metabolism to become water soluble. That is how exactly the link is. Okay, so clinical logic, what is the clinical logic here by these two fundamental things? Before, I'm saying before adjusting any of the dose, guys, always ask that which organ is primarily being responsible for clearing this drug. Okay, this is justified your why. Okay, it is not like something you are handling a prescription and seeing that the patient is having some drugs which can actually metabolized by the liver also and the renal route as well, which is involved. So how do you calculate further in this, right? So always ask which organ is primarily response, whether it is water soluble drug, lipophilic drug, what is the drug category. So you will have idea that which organ is primarily responsible for clearing this drug, whether it is hepatic or the renal route is involved. So for an example, I can say here some very basic example to understand. See, we have vancomycin, right? That is being excreted from the renal route, guys. Okay, we have meropenem, that is also the primary organ which is responsible for clearing meropenem is renal again. Okay, so kidney again. Next, on another hand, we have warfarin like drug. Okay, so yes, the primary organ is responsible for clearing warfarin is liver, guys. Okay, primary, both of it is involved, but primary is liver. And we also have diazepam. Diazepam is also like the organ is primarily being responsible to clear the diazepam is also hepat, guys. Okay, liver. So you need to ask always which organ is primarily being responsible for clearing this prescribed drug. This question can solve multiple things. Before adjusting dose, this is the primary thing to do, which many are failing. Okay, many people are not practicing in this sequence. They are doing directly based on the laboratory result. If the patient is having any type of creatinine clearance differences or AST, ALT differences, they adjust the dose. it is not how you can proceed, guys. Okay, you will end up with some therapeutic failure or toxicity maybe later. So this is a very primary thing to do. Ask that which organ is primarily responsible for clearing this drug. So this slide, builds the decision making, guys. This is called a decision making framework for all the future dose adjustment, I can say. How to start, where to start, right? So of course, just imagine if you are, started learning just now and directly you have put into the fifth standard. How exactly it feels like, right? It is not possible. We need to cross one, two, three, four, and then you can enter into the fifth class, right? So that is extremely important to follow the framework in the decision making. Dose calculation is one thing, guys. Okay, clinical judgment is the second, and for that reason, you need to understand the decision making skills. Okay, so that's the reason I am not only focusing on the formulas. Formulas are very important to memorize, but I know that you will. Okay, you will practice in the wards daily, and you will remember. It is not that hard. But the reason, justification, in which situation, these things are very hard to understand because it requires, it demands, concept clarity at a very root level. So this is how you can start your dose calculation while handling renal and hepatic dysfunction things. First and foremost thing is to ask the question. Now, let's start with some key renal function tests, and then we will move towards the liver also. First, we will understand some renal function test. Okay, you need to understand here the primary laboratory markers which are used to assess the quality, the kidney is having, how exactly the kidney is performing. We have lots of things in this particular category, renal function test. If I want to discuss about only RFT, I need 1.5 hours. Okay, but we are not here to discuss about the test. I am not deep diving into each of the tests. I will just brief you about what are the major things you can look for and how to adjust those as per the imbalance if you found. So this is our topic of discussion, right? So, first and foremost is this serum creatinine. Serum creatinine is abbreviated as SC and small r, that is serum creatinine. Now, let me tell you a very basic line what it is. So, this is, guys, a waste product. Okay, you can consider serum creatinine is a waste product from your muscle metabolism, right? And it always increase when your kidney filtration is getting decreased or dysfunction is there. Okay, serum creatinine is always increase in cases of kidney filtration decrease or any type of filtration issue is there. Shortly you can remember that. Okay, so just understand it is a waste product from the muscle metabolism, and whenever kidney is responsible actually, right, to throw it up. So that's the reason it is getting increased when the filtration is not happened adequately, we can say. So these are very important concepts. Next, we have BUN, which is again very important. That is blood urea nitrogen. So this blood urea nitrogen reflects, protein metabolism. Blood urea nitrogen itself, it has itself the little meaning. Okay, so it reflects your protein metabolism, which is affected overall by dehydration or diet is also the factor. Some internal GI bleeding is also the factor. So this BUN also you need to focus on. And last and very important we have, that is the EGFR. EGFR is estimated glomerular filtration rate, automatically reported by the labs. EGFR, automatically reported by the labs in the report. And this is a very powerful tool for CKD diagnosis, guys. Okay, so based on this EGFR, you can classify your kidney, chronic kidney diseases as well. So for CKD diagnosis, this EGFR is very important, but it is not ideal, for the drug dosing, guys. Okay, of course, you can take a look for it, but practically, when we are, doing a dose calculation for renal impairment patient, this EGFR tool is not ideal for drug dosing. Okay. Remember little bit. I will give you some example to understand how exactly it is making, not so much sense. Okay. In this is very important to diagnose CKD and some other things to check. But for drug dosing, EGFR is not ideal, okay? We cannot rely on alone EGFR. And next we have this creatinine clearance. First was serum creatinine, okay? So that was the waste product from the muscle metabolism. And creatinine clearance is, the best estimation for, we can consider the drug dose adjustment. The best estimation it can give you for any type of drug dose adjustment. Okay, especially in the pharmacy references, I can say creatinine clearance will be majorly focused when you are adjusting the dose. Okay, I will tell you how exactly you need to monitor it. I'm again repeating, guys, we are not deep diving into the renal function test because it is a huge topic, but our focus today is little different. Okay, we are here to discuss the dose related thing and dose calculation and dose adjustment. So our focus is on the doses, okay, and not the test. So I hope you can relate it. So let's understand first the serum creatinine limitation, and then we will go forward with the formula to adjust. Next slide will be the formula, but first you need to understand this thing. This slide is, I can consider, most important, okay? Most important in sense of concept. Conceptually, this slide is most important. You need to understand here why serum creatinine alone, that is misleading. Many healthcare professionals and pharmacy students are only focusing towards serum creatinine and they are doing the dose adjustment. But you need to understand that why this only serum creatinine is, misleading further, because as I told you, serum creatinine is a waste product of your muscle metabolism. It is depends on the muscle mass, right? So if the patient is elderly, or cathetic, or if the patient is having malnourished patient is there, that produces less creatinine, right? So serum creatinine alone can lead misleading. Okay, it can alone, it alone cannot be used for dose adjustment. Serum creatinine may appear normal also in some cases despite having poor kidney function, guys. Okay, that also you need to remember. So understanding why serum creatinine values alone can provide an incomplete picture of renal health, that is extremely important. So I hope you are getting the points, because many will tell you what to focus on. Okay, but I found this issue in the student category, that no one is advising them what not to focus on. Okay, that is exactly very important point. I have seen in my practice also that many patients are many healthcare professionals are adjusting the doses based on only the serum creatinine status, guys. Okay, but please understand, serum creatinine is only a waste product of your muscle metabolism, so it is completely depend on the patient. Okay, so if the patient is elderly or cathetic or malnourished, you will be having a variation in a serum creatinine. You cannot adjust your drug dose based on only serum creatinine, right? So for an example, I can give you here some example. So see this, it is affected by age and muscle mass in a one round, it is written, and you need to always calculate creatinine clearance. This is the gold standard for the dose calculation, guys. For that, we have one formula. I will let you know, but just understand one clinical example here. So imagine a case scenario where 80-year-old woman is having serum creatinine, 1 mg per dl. Now she can have, like, she may have this creatinine clearance, which is CrCl less than 30 ml per minute. So that is suggesting you a severe type of renal impairment. Even your serum creatinine falls under range, right? So this type of scenarios are very common in the healthcare, guys, in a daily practice. So, the message here is very simple, that normal serum creatinine does not mean you have normal kidney function. Correct? This is a very common intern level mistake you must, understand and avoid. Your serum creatinine can be normal and still patient might having a kidney related injury or kidney related issues. So that is very extremely important point. Now let's understand. I'm talking about since last two slide about the CrCl, creatinine clearance. So whenever we need to adjust the dose in the renal impairment cases, we need to focus on creatinine clearance. See, we need to focus on this serum creatinine, BU, and EGFR also, but the most important is creatinine clearance. Okay, so let's understand this Cockcroft-Gault formula. That is a very important formula to calculate your creatinine clearance. You need to understand the formula very slowly and with a very steady state. Okay, so understand creatinine clearance estimates for the how many milliliters of your blood the kidney can clear. Okay, that you need to understand. First, the meaning you should understand. What do you mean by creatinine clearance? So creatinine clearance estimates further how much, how many milliliters of your blood, how much ml, how many ml of your blood the kidney can clear of creatinine per minute. That is what the meaning of creatinine clearance, guys. Okay, you need to first understand the meaning. If you are noting it down, please note it down. This estimates how many milliliters ml of blood the kidney can clear of creatinine per minute. Okay, that is what the meaning is. Now, formula is very simple. See, the calculation is written here. So you just need to fill the values in it, and if you are using it for for multiple time in a word round and all, you will remember also. It is not that hard. So formula concept, see, you can see here, age is a very important factor. You need to do a like 140 minus age. So age is very important. Kidney function declines with age. That is the reason behind age is written here. Okay, kidney function declines with age. Okay, next important thing in the formula you can see is weight. So weight, why? Because reflects your muscle mass. Okay, weight is reflecting your overall muscle mass, and that's the reason behind weight is here. Also, I told you serum creatinine is not that important, but in formula itself, you need serum creatinine. Why? Because it is your filtration marker, guys. I told you in a very introductory slide, serum creatinine is a waste product of your muscle metabolism, and it is getting very much increased when kidney is not able to filter properly, adequately, right? So it is a filtration marker, and that's the reason behind it is important in the overall formula. Okay. And one more thing you need to remember here is you need to do female correlation factor. Okay, multiplication, that is 0.85. You need to multiply by 0.85 for females if you are calculating. Why? Again, the reason behind this is female are having more, females are more prone to having lower muscle mass ratio. That's the reason you need to multiply it by 0.85. This is universal formula. Okay, so it is predetermined, pre-synthesized, pre-decided. So please remember, for renal impairment cases, dose adjustment calculation is a Cockcroft-Gault formula you need to apply, where you will minus 140 minus age, and you will multiply it weight divide by 72 into serum creatinine. This is one of the important, very, I have examples, so don't worry. Just write it down, note it down, and understand the meaning of the calculation. Okay, so that is extremely important. Okay, so you may forget sometime many formulas, but this one you must remember, I say. Okay, this one you must remember, because renal adjustment cases will be large in your practice. Okay, so if you are handling elderly population and all, you will be seeing 90% of the cases where the renal impairment will be there. Okay, so you need to calculate those appropriately. So you will use this Cockcroft-Gault formula in those cases. Okay, so we have this weight selection strategy also in our upcoming slide, to understand how exactly we need to avoid some serious losing errors, weight related and all. I will let you know. Calculation example is also we have, so don't worry, but just understand what does this creatinine clearance means, and what are the important factor it has in the formula. Okay, age, weight, serum creatinine, and 0.85 for female, because female are more prone to have lower body, lower muscle mass overall. Okay, so that's the reason behind it. let's understand the weight selection strategy, because see, this slide is for preventing some serious type of dosing error, guys. Okay, so this is very important. You need to understand that using wrong weight that can overestimate or underestimate your creatinine clearance. See this formula, guys. Again, I am, um, um forwarding back. So you need to understand here the weight is written, right? Multiplication. So why this weight is so important? Because wrong weight, if you are entering into this formula, you can overestimate or underestimate your whole creatinine clearance. That is what the meaning is. If overestimation happens, you will end up taking overdose of the drug, right? If underestimation happen, of course, you will be having underdosing, right? So that's the reason behind this slide. So we can consider that this slide is for prevention of some serious dosing errors. Okay, because using wrong weight can overestimate or underestimate your creatinine clearance, that can lead to directly some overdose or underdose issues. Okay, you need to understand. See, I am explaining you very simply, it's a very simple way. If the patient is having normal, normal patient is there, you will take actual body weight, what the patient is having. But if the patient is underweight, guys, so what you will take? For underweight also, you will take actual body weight. Please remember, in the renal category, in a renal impairment cases, if you are doing a creatinine clearance calculation, weight is the very big factor. Okay, now we are understanding the formula in a more detail. Now we are diving deep into this particular formula. 140 is constant. Okay, minus age is also constant. Age you cannot change, but weight, there is a higher chances of error. Okay, that's the reason behind this slide in between. Okay, so how you will do it? If the patient is normal, like not obese and not underweight, you will take actual body weight of the patient. If your patient is underweight, again, you will take actual body weight in the calculation. But if your patient is obese, if your patient is obese, you will take adjusted body weight here in the formula. This is very important, guys. We cannot universally follow everywhere this Cockcroft formula. Okay. It is for the standard one. Okay. This formula is for standard one. If your patient is obese, you need to take adjusted weight. Now, I already told you in a very first or second lecture how exactly adjusted weight is being calculated. Okay, so ideal body weight and all. So formula is very simple to calculate adjusted body weight. Please remember, while applying in a Croft Gold, you need to understand in an obese patient, you need to take the adjusted weight. Okay, here it is written, you have actual weight, you have ideal weight, and you have adjusted weight based on the patient. There are three different weight selection strategies we are having. Okay, for normal and underweight, you can calculate actual body weight, guys, no problem. But for obese, we need adjusted weight. And to calculate adjusted weight, we need ideal weight also, right? So this is a very important topic you cannot forget. Okay, so in an, for an example, in an obese patient, if you are using actual body weight, you now know what will be happen next. You will be having creatinine clearance, which is very, very high. You can see the formula, it is in multiplication, right? So of course, if your weight will be high, your creatinine clearance will be high, right? So that's the reason your creatinine clearance will be very high. And based on creatinine clearance, you will be taking the dose, or you will be giving the dose of the drug. So you will lead to what? Higher antibiotic dose. What will happen next? Toxicity, right? So correct way selection is as important as the formula itself, guys. Okay, that's the reason behind this slide in between. Now, let's come towards the creatinine clearance calculation example so that everything will be clear to you. See, these are the steps. Age is 65. Age is 65. Weight is 60 kg. 60K, no, that is not 60,000. Okay, 60 kg, G is missing here. That's fine. Weight is 60 kg. Okay, the weight in kilogram utilized for the calculation. The age of the patient used in the numerator. Okay, or for the formula 65. Now, serum creatinine is 2 mg per dl. Okay, the lab reported serum creatinine value mg per dl 2. Okay, how will you calculate? How will you calculate? You have formula, you can try it. Okay, and the answer is written here, but you can try by yourself that are you getting it or no. I will let you know what will happen in the patient if the patient is bedridden. Okay, don't worry. But let me know you are getting the 18 answer or no. 65 is the age, and apply this formula, guys. Apply this formula and calculate, and just let me know you are getting the answer 18 or no. If yes, thumbs up. If no, you can put your queries. Are you getting it? Okay, so I'm happy by your answer. Male patient it is, yes. 140 minus age into weight and 72 serum creatinine. And yeah, of course, you if the female is there, you will be doing multiply by 0.85, right? But it is very simple calculation you can have for this, final value for is 18. Okay, 18 ml per minute. I told you creatinine clearance exact meaning also. Okay, I told you exact meaning of creatinine clearance. Okay, and that is per minute. So unit will be milliliter per minute. Don't forget that. Okay, so this patient has yes, several renal impairments, meaning we can say most of the renally cleared drugs need further dose reduction for this patient. Some drugs may be contraindicated also, and monitoring will be mandatory in this case. Okay, so this slide links numbers to, we can say, clinical decisions, right? Whatever we are taking. So this is how you can calculate your creatinine clearance based on the patient's age, patient weight, the serum creatinine, and the gender itself. And you can calculate the whole thing. And see, this is the very simple formula you can use, but the meaning is huge, right? Most of the renally clear drugs needs dose reduction in this particular patient, and some drugs still may be contraindicated, so you need to identify what are those. Now let me give you idea about the CKD staging, guys, based on the creatinine clearance whatever you are getting. Okay, so see, this is very simple. CKD staging further help us to predict the disease progression itself. Of course, it is guiding the drug dosing, and it is also deciding the monitoring frequency, right? You need to understand that if your creatinine clearance ml per minute, if it is greater than or equal to 90, it is normal. If it is mild, you will be getting the range between 60 to 89. If it is moderate, that means 30 to 59. Severe, that means 15 to 29. And if you are getting it less than 15, it will be ESRD situation. Okay, so this is extremely important, guys, to understand. If the patient is fall under the mild category, usually there is no dose adjustment will be needed. But if the patient is fall under moderate category, after Cockcroft Gault formula, you are getting the creatinine clearance. If the patient is fall under moderate category, you will be needing partial dose reduction. Obviously, you need to do a reduction, right? The another method is also there, that is increasing interval. I will discuss later, don't worry. Okay, but for now, dose reduction. Okay, if the patient falls under the category of severe, what you will do, major dose reduction, or in some cases complete avoidance. Okay, and in the ESRD, so there is only a one option, that is dialysis consideration, right? So yes, this is very important. And what is the clinical relevance is, most of the hospital admissions are, fall into this moderate to severe category. Okay. Most of the hospital admissions are falling under this particular moderate to severe category. Not normal, not normal kidney function. So whatever patient are admitted in the hospital, they fall under this category only, that is moderate to severe type of CKD. You will find a creatinine clearance range of 30 to 59. Okay, so that falls under moderate to severe category, and in this situation you need to perform this dose calculation and how to exactly adjust your dose further. Okay, so we can consider that dose adjustment is a stage based, guys. It is not symptom based. We cannot focus on symptom only. We can focus on stage first. Okay, so patient is in which stage. Sometime I have also seen in my practice that people are adjusting dose if the patients are falling under the mild category, right? So that situation also you will face. While our guidelines and standard things are suggesting that in the mild situation, if the creatinine clearance is up to 60 or 89, you don't need to do a dose reduction. But I'm not saying that they are wrong, but what is the scenario is you need to completely understand the clinical picture in that context, right? Might be patient needs it, right? So in this scenario, yeah, you will be getting dose reduction even if the patient is having mild category. Okay, so that is the reason behind it. Every case will be unique, and every calculation will be unique. So of course you need to understand in that sense. Okay, so this is very important thing you can do. After creatinine clearance calculation, you will stage your chronic kidney disease, right? Next will be the renal dose adjustment rule. Now there are certain rules, guys. We cannot uh, avoid that. I told you already in the previous slide that yeah, we can reduce the dose or we can increase the intervals, or in some cases both, right? So anyway, our aim is very simple, that we have to give our the patient's kidneys more time to process your drug. Whether you are reducing the dose, whether you are increasing the intervals between the two doses, both of it has the same aim. So this slide is particularly explaining how we are modifying the doses. Okay, so once your renal impairment is identified after calculating creatinine clearance and the stage, there are three core strategies you can apply. Very first is directly reducing dose. 90% of the cases, people are, healthcare professionals are practicing this first step, which is reducing the dose. So you keep the same dosing interval here, like whatever, one in the morning, one in the night, whatever you are following, but you will reduce the overall amount which is given each time. Okay. Now this is used when I can say steady drug levels are required. Okay, so with some narrow therapeutic index drugs, we need steady level in the plasma to achieve the therapeutic efficacy of the drug. In that sense, you cannot increase, you cannot decrease the interval. Or sorry, you cannot increase the intervals, right? So you can focus on reducing dose instead, so that you can maintain the steady plasma concentration to achieve the therapeutic efficacy, right? So for a very good example in that reducing dose scenario, I can say is the digoxin, guys. So digoxin के साथ ये बहुत होता है. It is very common with the digoxin. Dose reduced, because even small accumulation happens with the digoxin that can cause very serious problem associated with, arrhythmias and all. That's the reason we cannot and also we need to achieve the maximum safe concentration and steady concentration in the plasma to get the therapeutic efficacy of the drug. So digoxin, associated with digoxin, there is only one option to reduce the dose, right? So that is extremely important to understand. Also, the another thing we have, that is increasing the dosing intervals. Increasing interval, that means increasing the dosing intervals. So here you will not reduce the dose, but you will increase the interval. Okay, so you give the same dose here, but increasing the time between the doses. So this is commonly used for, I can say, antibiotics. Okay, these are very important strategies. Increasing interval is very important strategy for antibiotics. For an example, I can say meropenem. Meropenem, 1 gram. Okay, 1 gram is the dose which is ideally being prescribed for 24 hours in several renal impairment cases. You can increase here the intervals associated with it, right? So I have seen in my clinical practice, like digoxin, if it is there, they are always trying to reduce the dose. And if some antibiotics like meropenem and all there, they are trying to increase the intervals in between, right? Or in some cases you can do both techniques together. So that is, you can assume, right? Both, that means it will be used for some high risk drugs. Okay, some high risk drugs where both like dose and interval, both of the things matters, right? So the choice is depend completely on the, I can say, on the drug's own half life, what is the therapeutic index the drug is having, like whether it is neurotherapeutic indexed drug or no. And also I can say some point, infection, okay, infection severity the patient is having. So all those factors depends that what you will choose next as a strategy to reducing the concentration or adjusting the concentration of the drug in the body. Okay, so this is again a important slide to understand. Now, you need to understand antibiotic requiring adjustment, guys. So, I have some of very important antibiotics for you to discuss. This slide highlights you some high alert antibiotics that that must never be given blindly. We need to calculate everything related to this. Okay, some high alert antimicrobial therapies you can consider meropenem, aminoglycosides, and vancomycin that must be modified based on your creatinine clearance, whatever you are getting from Cockcroft God formula, right? So first we are having, let's discuss first this vancomycin, okay, because that is a very important drug. So vancomycin, I already told you in the introductory slide that it is being primarily excreted from the renal route. So it can actually accumulate very, very quickly, okay? That is the reason behind it is high alert antibiotic. And if the patient is having renal impairment and having a vancomycin, that requires tough monitoring, continuous monitoring, I can say, because it is directly having nephrotoxicity, and it is leading to the renal failure and all. And some autotoxicity related risk is also there associated with the vancomycin use. Sometime in many cases, they are avoiding completely these high alert drugs, but in rare cases you will find also. Okay, so if there is no other option available, so yeah, that is what the vancomycin is having. Next, let's discuss about aminoglycosides. So aminoglycosides, I hope you have idea, gentamicin and amikacin and all, right? So neurotherapeutic index drug it is. Okay, so we have very less difference between minimum effective concentration and maximum safe concentration. It is a neurotherapeutic index drug, and also it follows, I can say, concentration and concentration dependent killing, of course. So we need to maintain a steady concentration in the plasma if you are aiming for a therapeutic efficacy which aminoglycosides can provide. But the important thing here is, of course, renal accumulation happens in the case of renal impairment with aminoglycoside, and that can worst further your kidney damage. Okay, it can give irreversible damage to the kidneys in cases of renal impairment. Also, we have meropenem with us, which is again renally eliminated drug. And overdose if happens with the meropenem, that can cause directly some serious type of side effect like seizures. Okay, so antibiotics are very commonly used in the critically ill patients, of course, who already have, unstable renal function. But our responsibility is to adjust the dose early as possible, not after the toxicity occurs, guys. Right? Because after that, the whole scenario will be different, and that will be the topic of toxicity management. Right? So, another topic to discuss. Another topic is like drug induced toxicity management. Okay, so treatment of drug induced conditions, those are the topic again to discuss further. But here we need to calculate and we need to adjust the doses before the toxicity happens. So that's why I have included these high alert antibiotics for your reference to understand those calculation, how it is, matters, and in which time, at which time you need to perform it, right? Now, see this antibiotic case. This is again very important to understand. Here here you will experience clinical decision making by this case only by understanding. So this is only for your understanding purpose. So see, this scenario is very simple. Standard meropenem dose is 1 gram, right? 1 gram every 8 hour. And patient has here, in this case, low creatinine clearance. That means it falls under some moderate severe category of having CKD. And kidneys cannot clear the drug, fast enough as it should be, because of course patient has the condition. So if we continue this dose, like every 1 gram every 8 hour of meropenem, what happens next? If you are continuing the same dose, of course your meropenem will accumulate. It can lead to some serious problem like CNS toxicity and seizure related problems will be there. So pharmacist duty is to intervene this type of cases, guys. Okay, and you can here recommend for the 1 gram every 24 hourly rather than 8 hourly. Okay, you are not here reducing the dose, you are here increasing the interval. Okay, you are increasing the whole frequency. Okay, I told you in digoxin type of things, of course you need to reduce the dose, but in cases of this meropenem and all, you need to what, you need to update the renal, update the interval type of the frequency, you need to update, right? So key teaching message from my side here is very simple. Like dose adjustment is not about only the dose reduction, guys, right? Timing also matters, and you can suggest this, right? So this slide is helping you to understand why exactly interval adjustment is, often preferred for high risk antibiotic like this. So next time if someone asks you that the dose calculation is always about dose reduction, no, it is all about timing and then dose reduction as well. It is completely depend on the clinical context you are solving. Okay, so formula is very simple. Calculation, you will do it. I know that you will apply your mathematical skills. You will put some values in the formula, and formula is also available. Everyone is having that digital tool in our hand, right? Mobile, tablets, iPhones, and all. So everything is available on a one click, guys. Right? Formula, you will find it very easily, and you can calculate also in a daily life. But what next? Right? That is extremely important, and how exactly you need to perform the dose calculation, right? After apply your whole digits into the calculation, getting the values. If once you are having creatinine clearance in your hand, you can further stage your patient's condition, whether it is moderate, severe, mild, what it is, and based on that you can further examine which drug is prescribed, whether it is high risk antibiotic, whether it is broad spectrum, what is exactly the medicine. Okay, which organ is being primarily targeted, that is also another topic to discuss. After liver examination, I will tell you the flow, and then you will appropriately calculate the strategy of doing the dose adjustment. It is adjustment, not always reduction. Okay, so this is the antibiotic case you need to identify. And one of the major thing I want to discuss here is anticoagulants and the renal function, guys, because this is, extremely important. You need to understand here, anticoagulants are silent risk, guys. Okay, so anticoagulants are silent risk, like, it is a silent risk drugs we can consider. We will focus here on the very important agent, that is enoxaparin. Also, we have this direct oral anticoagulants, DOACs, that is direct oral anticoagulants. Okay, so see, renal impairment cases reducing the clearance, right? Overall clearance of the drug. And it directly leads to higher plasma concentration of the drug. So, of course, it can lead to increased bleeding risk, guys. So, whenever renal impairment case is there and patient is receiving anticoagulants for some other indication, enoxaparin or some direct oral anticoagulants, you will be having direct risk of internal bleeding. Okay, so bleeding, may not be obvious initially, I can say, but by time it appears, right? It appears in many cases, and damage is already done if you are getting it, right? So what is our role here? If the patient is having renal impairment, you are classified creatinine clearance by applying formula, and you stage also your patient, and you found that patient has renal impairment things, moderate, severe, mild, whatever it is, and you find this anticoagulant in the prescription. Your role here is to check the creatinine clearance before anticoagulant initiation. Okay, before anticoagulation therapy initiation. If it is there, if it is the disturbances in the creatinine clearance, anticoagulant dose adjustment will be needed. You need to adjust the dose very, very proactively, whether you can reduce dose, whether you can increase intervals, or maybe both, depends on the situation. But if this is the thing, you need to do it, right? So I have another case also to make you understand more about this. See this is a very important case we can discuss here. Here, the normal renal function is there. Like enoxaparin is being given 1 mg per kg every 12 hourly in a normal renal function case, guys. Okay, 1 mg per kg you need to identify. So if the patient is having 50 kg weight, 50 mg, right? 1 mg per kg, 24 hourly is the normal dose, normal renal function category dose. But in condition of renal impairment, guys, renal impairment cases, you need to adjust it 24 hourly. Okay. So 1 mg per kg every 12 hours, sorry, every 12 hour is normal renal function. Okay. If the patient is having normal renal function, enoxaparin 1 mg per kg every 12 hourly is being normally prescribed. But in renal impairment, you will increase the interval here and you will make enoxaparin 1 mg per kg every 24 hourly. Okay. So why this interval is being increased here? Because now you can have idea, drug stays longer in the circulation in the renal impairment cases. You can actually prevent the accumulation and the internal bleeding risk by increasing this, interval from 12 hour to 24-hour. Okay, so pharmacist, if doing this, suggesting this as an intervention, you are actually preventing bleeding events before they happen, guys. Okay, not after what INR is suggesting after in a lab report. That is what I have seen in my practice, right? So that's where some of the very basic fundamental things you can carry in your mind, and you can write these things in pharmacist intervention and suggestions, and you can discuss also with your healthcare team about this, and you can calculate the whole thing before any type of anticoagulation initiation happens in the renal impairment cases. Okay. Last thing I need to discuss in the renal impairment is this anti-diabetics. Okay, so you need to understand why diabetes and kidney disease often coexist, guys. It is always like whatever case is there, CKD patient has diabetes, right? Why diabetes and kidney disease often coexist? So we have here the two major problem, guys. Okay, we will discuss about metformin and insulin. So metformin is renally excreted, right? It is renally excreted, and insulin is also cleared by the kidneys. Metformin, if the accumulation happens, you will directly have lactic acidosis like situation, and lactic acidosis is life threatening. Okay, and if insulin clearance is reduced in the renal impairment cases, if the patient is taking insulin and clearance is being reduced, you will be directly having a hypoglycemia risk, hypoglycemia episode, right? That's the reason we need to take care of anti-diabetic agents into the renal impairment cases. So I told you three major things here, guys, in renal impairment. One is the Cockcroft-Gault formula for creatinine clearance calculation, right? First, I told you the renal function test you need to identify serum creatinine, BUN, and creatinine clearance and EGFR, right? Creatinine clearance you need to calculate by using this Cockcroft-Gault formula. Once you will have this creatinine clearance in your hand, you will stage your patient, and you will next focus on the prescription, which are the tablets which are being prescribed or medicines which is being prescribed, whether it is anticoagulants, whether it is antibiotics, whether it is anti-diabetics, because these are the commonest agents you will find in the prescription. And everywhere you need to do a dose adjustment. Okay, dose calculation is one thing, guys. It is a simple step, just a formula and some digits, that's it. But what next? That is what the bigger picture is, right? So when it is antibiotic, you need to take care whether it is meropenem related things or digoxin related things, right? How to reduce dose, how to increase intervals, or in which scenario do you are doing both, right? These are very important things. And anti-diabetic, of course, it will be there in 90% of the renal impairment cases, guys, because diabetes and kidney disease often coexist together, right? So this is the reason behind it. In CKD patient, you know what? Even usual insulin dose, I told you yesterday, I think, in IV infusion, that insulin is, international unit, right? So even usual insulin doses that can cause sudden hypoglycemia in the CKD patient, and if not taking, it will be having a sugar spike, right? So this is very common scenario in elderly patient. If they are having more than 65 years of age, you need to take care of these things. Okay, so in renal diseases, anti-diabetic drugs becomes high risk drugs. Just one line. Okay, so you need to understand that. For that, I have one example also, metformin cutoffs, guys. So you need to understand how exactly it is being taken. I will explain you the logic also behind this cutoffs. See, if the patient's EGFR level is greater than or equal to 60, that means kidneys can clear metformin very safely. Okay, so EGFR, that is estimated glomerular filtration rate. Filtration rate is higher, that means kidneys are working in a good way. Okay, that's the reason filtration rate is nice, right? If it is decreasing between 30 to 45, okay, 30 to 45, that means their clearance is reduced, filtration is reduced, and here you need a dose reduction. Dose reduction is needed. Okay, clinical action will be reducing the dose. And if EGFR is less than 60, that means you need to stop your metformin use. It can lead to severe accumulation, and it is, I can say, it is contraindicated, guys. If the patient's EGFR is less than 30, using anti-diabetic drug is contraindicated. Okay, so if I can give you example here, just imagine a patient with EGFR 28. Okay, EGFR 28, which is less than 30. Now, in this situation, 28 ml per minute, continuing this metformin, that leads to higher risk of lactic acidosis, especially during, infection and in this situation. So what you will do next? You will stop metformin immediately, right? During this contrast imaging or sepsis or acute kidney injury, all those things, metformin will be contraindicated, right? So these are extremely important things you need to take care of while doing a dose calculation and after dose calculation. Okay, so I hope now it is clear to you how exactly renal dose calculation is very simple. Renal impairment calculation is very simple, but what next is difficult. And we are here to suggest something, not only calculate something, right? So after things are very important, right? Next, last slide for the renal impairment things, that is the drug accumulation risk. I already told you these things, but still I will little bit explain you more about this. So you need to understand that narrow therapeutic index concept. Okay, so we cannot tolerate a small difference between the effective dose and toxic dose. We have a very small difference between effective dose to maintain and a toxic dose above which we cannot proceed. Okay, so for drugs like digoxin and all, that it can actually accumulate. It can leads to arrhythmia, nausea, or some type of visual disturbances as well. I have seen in my clinical practice this type of scenarios. And they, I can say, they wrote there the ophthal reference and all, because of some disease related issue. Family is wondering that that might be reason behind visual problem is some disease related things, but actually it is drug related things, right? Only we can understand that. Yes, so digoxin has that side effect of higher at a higher dose, it can leads to visual disturbances as well if it accumulates in the body, right? Also, we have lithium. So if lithium is accumulating, if you know, lithium can trigger to directly tremor situation, guys. Okay, tremor, seizures, extreme confusion state. You know lithium, right? So yeah, lithium, if overdose is happening with this. Aminoglycosides, I already told you, it is nephrotoxic agent. If accumulation happens, it can lead to serious renal failure things. Okay, so it is a nephrotoxicity, and some type of autotoxicity is also the drug accumulation risk with this. So see, the message is these drugs, demands dose adjustment, guys, and monitoring. How you will monitor? Of course, by creatinine clearance, you will monitor, and you will monitor by the therapeutic effect and the side effect profile. Okay. So yeah, these drugs demands dose adjustment. You need to be aware of the situation where the dose adjustment will be needed. You need to be aware of the antibiotics or any of the drugs that needs dose adjustment, both of the scenarios simultaneously. Okay, so I hope now it is making sense to you how exactly renal impairment cases is needing a dose adjustment and calculation. Okay, so now we are proceeding towards the hepatic dose adjustment topic, which is again as important as the renal one. So yeah, so far we discuss about kidneys. Now we will talk about the liver. Okay, you need to understand that liver is the primary organ that metabolizes your drugs. Okay, liver diseases that can actually reduce the whole enzymatic activity, guys. Okay, whole enzymatic activity, you know that we need enzyme for conversion. Okay, we need enzyme for conversion from inactive molecule to active molecule and all of these things. So drugs will stay longer period of time if the patient has hepatic impairment, and the same scenario will happen as the renal impairment case has, that is higher plasma level of the drug that can lead to potential toxicity. If the free drug is there, that can lead to toxicity. So important concept we will discuss here is, in liver disease also we have some formula to apply. So in liver disease, free drug concentration increases due to this metabolism related issues. Okay, reduce metabolism and reduce protein binding. Okay, so reducing metabolism, reducing protein binding, these are major issue happens. And of course, normal dose can behave like an overdose if the patient is having hepatic impairment. Normal dose can behave like the overdose, right? So let's understand first the liver function test, and then we will understand in the same flow as we understood about the renal function. So you need to understand this difference between the damage markers and the function marker, guys. Okay, so what are the damage markers and what are the function markers? What can show you the liver function and what can show you the damage, that you need to differentiate. Okay, you need to understand the difference. We have first the AST, ALT. These are two very important markers we can consider. This actually indicates the liver cell injury. Okay, so these two are very important. I will let you know how exactly it is being calculated later for the dose adjustment. But just understand this AST and ALT. Many of you might be already aware of this idea, SGPT and SGOT, right? That can indicate liver cell injury. Okay, it is not reflecting dosing capacity directly. Please remember that AST ALT do not reflect dosing capacity directly, but yes, it can indicate liver cell injury. Next we have INR with us. That is reflecting this INR is reflecting clotting factor synthesis, guys. Okay, so INR is responsible for indicating clotting factor synthesis to you, and it indicates also the true liver functional impairment. Okay, so if the patient's liver has a minor functional impairment, your INR ratio will show you. Okay, and another we have albumin. So as I earlier told you, protein binding, right? Reduce protein binding. So of course, albumin is reflecting protein synthesis. If you have low albumin, you will not have enough binding. Okay, and more free drug will be there and more chances of toxicity will be there. So if albumin is less, of course, normal drug will behave like a overdose because they are not bind it properly for giving you the further effects. So yeah, dose adjustment decisions are majorly, I can say, rely on, this INR and albumin then as compared to AST, ALT and the ratio of AST, ALT alone. So we cannot always focus alone on AST, ALT and the ratio of it. But yeah, dose adjustment decisions are rely on INR and albumin. Please remember these things, very important. Okay, so because many healthcare professionals and many interns and students are practicing dose calculation only by seeing AST, ALT because they know only one thing, that ASTLT abnormal hai, that means patient has liver disease, right? But if you want to, it is ultimately indicating the liver cell injury, guys. Of course, you are right here, but you need to understand that if you want a dose calculation, just a minute, I think. Okay, if you want a dose calculation, you need to focus on this INR and albumin. Okay. Now, as in the renal category, we were having a Cockcroft Gold formula. Here we have a child pug score. Okay. Now here there is something difference between formula and score, guys. Okay. So that was the formula to extract creatinine clearance. Here we have a child pug score to identify. Now this slide is introducing you how exactly we assess the severity of the liver disease. This is a score, right? So whatever score the patient is having, it will directly tell you the severity of the liver disease it has. Okay, in a very clinically meaningful way we can consider. So you need to understand that Child-Pugh score is not about diagnosing liver disease. Please understand that the child pug is not about diagnosing the liver disease, but it is about grading. Okay, score it is. So it is about grading that how badly the liver is functioning right now, at what stage it is, how bad the liver is functioning. Okay, that is directly affect your overall drug dosing. So that's the reason child pug score is extremely important. Here we have four things which are very important. See, one by one, we will understand. Just first line for your understanding, we have five clinical and laboratory criteria which are used to calculate the hepatic impairment severity. I will let you know one by one what are they. So, very first we have that is the bilirubin, guys. Okay, we have bilirubin with us. You might be aware of the idea of bilirubin and liver, right? So, bilirubin indicates what? Bilirubin indicates bile excretion function, how much efficiently your bile excretion happening, that is bilirubin. So if high bilirubin is there, that means poor clearance of bile happens, and if poor clearance of bile is there, poor clearance of drug will be also there. So if high bilirubin if found in the patient's report, you need to understand dose adjustment will be needed, right? Next we have albumin. So I told you it is a protein binding, so it reflects protein synthesis. If you have low albumin, that means you have no binding agents with you, right? So low albumin increases your free, that means, active drug concentration freely roaming. That is again leading to toxicity. So albumin if is again important, but it is like if we found higher bilirubin and low albumin, it is suggesting dose reduction, right? Please remember this thing. Apart from that, we have, yes, I told you we have INR, which is not written here, but please understand INR is also important. It is giving you idea about uh, clotting factor, right? INR is the abbreviation for International Normalized Ratio. It is reflecting clotting factor synthesis, guys. So if high INR is there, that means there is poor synthetic liver function. Your function is not properly done by the liver, right? Directly, it is giving you the idea. So of course, it suggests you to do the dose adjustment. Next, it is written here that is ascites. Ascites is a clinical marker I can consider of, any type of portal hypertension if the patient is having. So it indicates advanced type of liver disease if the patient is having ascites, guys. Okay, so it indicates advanced type of liver disease. And next we have encephalopathy, which generally, explain as an hepatic encephalopathy. So it is nothing but a neuropsychiatric effect. Okay, neuropsychiatric effect of your liver failure. That is what hepatic encephalopathy means. Now, this shows failure to, I can say, detoxify your ammonia and all of the drugs also, right? That is hepatic encephalopathy. What is the clinical relevance here? So these parameters, bilirubin, albumin, INR, ascites, hepatic encephalopathy, these all parameters, the all five parameters together give you a global picture of hepatic capacity, guys. So if you are measuring bilirubin, if it is high, if you are measuring albumin, if it is low, if you are measuring INR, if it is high, if ascites is present, if hepatic encephalopathy is present, these five parameters together can give you a very big, broad, global picture, I can say, of your hepatic capacity, of your liver state, not just enzyme elevation alone, AST/ALT, right? So, of course, we will see SGPT, SGOT because it gives you an idea about the liver cell injury, right? But these five, INR is not written here, but these five parameters are there. Bilirubin, albumin, INR, ascites, and encephalopathy works together and give you the global picture of hepatic capacity. Now let's understand the child pug classification. As I told you, this is not a formula, it is a score. Okay, so here we have class A, class B, and class C for what? Child pug classification. Okay, so here, the score is there to translate into the clinical severity. So if the patient is having 5 to 6 points, guys, if the patient is having only 5 to 6 points, see, child pug is very simple. They are, it is only score based thing. Okay. So if the patient is having this symptom, one score, this symptom, two score. If laboratory thinks this, one score. So this is how you can calculate the score in the child pug. And if the total falls under 5 to 6 points, it is a class A. That means it is suggesting a very mild type of liver dysfunction. And most of the drugs that can be used in a class A, but with a caution, monitoring is required. Okay, no adjustment will be there in a class 1. But if the patient got a child pug score between 7 to 9, now in child pug they have assessed these things, okay, bilirubin, albumin, ascites, encephalopathy, and all. So if the patient is receiving moderate points like 7 to 9 points, it suggests moderate dysfunction of liver. And in this scenario, many drugs needs further the dose reduction. How to do it, I will let you know. And in class C, that is patient is receiving highest point, that is severe dysfunction of your liver. So many drugs will be directly contraindicated in class C. Okay. So drugs, you need to understand that drug monographs, often state here like use with caution in the child pug B, avoid in child pug C. Some drugs has this monographs on its own, like a label. So if the patient is having child pug score B, avoid this drug. If the patient is having child pug C, complete contraindication. If child pug A, we can use this drug, but with a caution. This is how they, explain. So child pug class matters, I can say, more than AST/ALT numbers for dosing, guys. AST/AST is for understanding your disease progression and the disease state and the physiology related things. But for dosing, of course, child pug is very important. In child pug, we have these things. Okay, INR, albumin, and ascites, bilirubin, hepatic encephalopathy, and all. Based on that, they are getting scores, and based on the scores, they further intervene that the dose adjustment is needed or not needed. Okay, so let's understand further drugs needing hepatic adjustment. So you need to understand here why certain drugs are dangerous in the liver disease. Of course, statins. Okay, all our atorvastatins, and rosuvastatins, and all of our statins. These are very important drugs in prevention of heart attack, guys, right? But still, statins are metabolized in the liver. Okay, it will be carrying the risk of hepatotoxicity. The risk will be high in cases of hepatic, impairment. And it can actually, statins are, low. It's very important in cases of lower doses, or avoidance if it is needed. So if the patient is having hepatic impairment, you can lower the dose of statin, or you can avoid in certain condition completely. Okay, based on what the status of bilirubin, ascites, hepatic encephalopathy, bilirubin, all of those data and child pug things you can consider further. Next, we have benzodiazepines. So if the patient is taking benzodiazepines, of course, long half-life benzodiazepine is having in the liver disease. Okay, in the liver itself, right? So in the liver disease, it will take a lot of time to, metabolized by it, and it can cause prolonged type of sedation, and it has risk of encephalopathy itself. So benzodiazepine is also high risk drug we can consider for hepatic impairment patient. And we have opioids on another hand. It can, actually reduce the metabolism, and it can increase respiratory depression risk, I can say, opioids. Okay. So for opioid use also, like morphine and all, we need to do a dose adjustment if the patient is suggesting hepatic impairment based on Child-Pugh score. So in liver disease, normal doses behave like overdose of this statin, benzodiazepine, and opioid like medicine. Okay. I have one of the case example for your understanding. See, you need to understand this is where, clinical judgment is being tested. So see, diazepam is here, and diazepam, if I can say category, is a very highly lipophilic drug. Okay. Diazepam is a lipophilic drug. It has long half-life, and it is extensively metabolized by the liver. Okay. And you can see this case, a specific contraindication and clinical decision point for patient with severe liver failure. Decision was identified that avoiding diazepam in Child-Pugh C. Now, this is universally accepted sentence, guys. Okay. So in Child-Pugh C category, you can understand Child-Pugh C. That means many drugs will be contraindicated, including this diazepam. Because of clearance is severely reduced in Child-Pugh C category, drug can accumulate very rapidly in it, and high risk of coma and respiratory depression it is carrying. Okay, so that's the reason avoiding diazepam completely, or using on a safer perspective, that you can go with it. Short acting alternatives, at a very minimal dose you can suggest here. That is what the alternative you can suggest. So in, a very severe type of liver disease, avoiding a drug is sometimes the safest dose adjustment you can do. But then when it comes to Child-Pugh C category, right, avoiding the drug is the safest dose adjustment you can do. Now I have renal versus hepatic comparison for you, as hepatic impairment thing doesn't have multiple things into it. Child-Pugh is the only thing we are focusing on, and based on that we need to do a dose reduction and, interval setting. So renal versus hepatic comparison. This slide further give you idea about organ based decision, guys, and the logic also. For an example, if vancomycin is there, primary elimination pathway is renal, and if warfarin like drug is there, hepatic, metabolism is primary elimination pathway we can consider. So in vancomycin, we will check if the patient is taking vancomycin. Of course, in that patient, we will check first, we will calculate this Cockcroft-Gault formula, and we will check creatinine clearance in this particular patients. If the patient is taking warfarin and all, we will monitor INR, we will monitor liver function test, we will monitor bilirubin, albumin, and we will monitor hepatic encephalopathy, we will monitor ascites in case of warfarin. So after looking at the drug name and after understanding which is the primary elimination pathway it has, whether it is renal or hepat, you can focus on the laboratory thing, guys, and based on that you can do a dose calculation. Okay, if it is renal, you can go for Cockcroft-Gault. If it is hepat, you can focus on the Child-Pugh. Okay, so we have here the real lab report approach with us. So this slide reflects the actual ward workflow, guys. Step one is always check creatinine clearance before renally cleared drug you are, dosing, you are adjusting. Okay, and check always liver function test. That includes all Child-Pugh factors, right? Check LFTs and Child-Pugh before hepatically cleared drug before dosing. Okay, these are the very important steps you can consider. Third step, which is not written here, but third step, after you will check creatinine clearance and LFT, third step, you will check the, I can say, high risk drugs. If it is renal, you will check whether the patient is taking antibiotics, whether anti-diabetics, whether anticoagulants, and you know now how to handle it, right? Next, you will check high risk drugs for it. Okay. On a right side, you can just assume whether it is diazepam, digoxin, right? On a step four, I can say you will recommend dose adjustment further, in which you can recommend as a pharmacist whether to reduce the dose or whether to increase the intervals. Now you know at what point you can do select. Okay, so if the neurotherapeutic index drug is there, you will reduce the dose. In if you cannot interval, you cannot increase the intervals in some cases. So based on that parameter, based on what your case is having, the background, you can select, right? That is the fourth step. And fifth will be, of course, you will document it, right? So this is how you can take the approach. Okay, this systematic approach, I can say, it can prevent your trial and error dosing problems, some serious type of adverse drug reaction, and some serious type of prescribing error also it can minimize. What are the common intern mistakes? Let me tell you. Okay, so this is very important slide to warn you. Okay, so commonest errors I found, that is ignoring patient weight, first of all. Okay, so ignoring patient weight is the very important error you can consider, because if the patient is obese, you need to take adjusted weight, and if the patient is underweight or normal, you can take your actual weight. So ignoring weight is the biggest mistake in the you can make. Also, the another mistake I can say, using only the EGFR instead of creatinine clearance. So sometime sometime interns and students and healthcare professional has a very simple thing fit into their head, that is only estimated EGFR, estimated glomerular filtration rate is the only parameter that can show you the whole picture of kidney, right? But it is wrong. For this renal impairment dose calculation, you need, guys, here creatinine clearance, not EGFR. Okay, so using EGFR instead of CRCL, that is also one of the mistake. Also forgetting that, in female category, forgetting that correlation factor multiplication, right? That is also one of the mistake. And sometimes copying doses without checking the laboratory and using the whole wrong formula, that is the commonest mistakes you will find. So this mistakes leads to, of course, overdose, toxicity, prolonged hospital stays and all. So guys, most of the medication errors happens, not due to the lack of knowledge, I can say, but lack of attention to detail, right? So that is extremely important. And what is the pharmacist's role? Let's discuss briefly. So this slide is again defining your own roles and responsibility very, very professionally. I already elaborated that how you can systematically approach this type of queries, and how to do dose adjustment in hepat and renal impairment cases. Systematic approach, I told you, right? Step 1, step 2, 3, 4, 5. So of course pharmacists are here to ensure patient safety, optimize the therapy based on the laboratory, preventing toxicity, and supporting prescriber with evidence based recommendations. You can do the recommendation, you can give them the recommendation. Okay, clinical reality is very different, guys. In ICU and wards, pharmacist interventions actually means a very it is matters most, right? Pharmacist intervention reduce mortality, guys, and ADRs, serious ADRs. So you are not just here dispensing and making a calculation on a paper and pen, with paper and pen. You are protecting patients, so you need to behave like that. So, what are the key takeaways from this whole thing is a summary of the most critical points, regarding dose adjustment in the clinical pharmacy. Lab guides dose decisions, right? So, lab drives the dose decision. Like, for an example, creatinine clearance is essential for renal dosing. Child pug guides hepatic safety. I can say high risk drugs demand some extra caution. You must be aware. And dose adjustment is a clinical skill, I can consider. Okay, it is not a only math. Okay, so always respect the labs before respecting the dose, I can say. Right, you need to understand what to look for. And what is the closing? Clinical precision saves lives. So that is a closing message from from my side today. Like, what is the meaning of clinical precision? That means wrong dose can harm faster than the wrong drug, I can say. If you are not maintaining a dose correctly, it can harm faster than you are selecting a whole different drug, right? And pharmacists act as the last safety checkpoint. You cannot forget that. Okay, so yeah, anyone can calculate a dose, anyone can remember the formula, and anyone can put the values in it. We all have calculator in our hand. In minutes we can do calculation, but only a skillful clinical pharmacist knows when exactly it is being applied, how exactly it is being applied, and whether to give it or no, in which situation what to do. Right. So yeah, anyone can memorize a dose also, but a skillful clinical pharmacist knows when not to give it, in which scenario it is specifically contraindicated. So you need to respect the kidneys, guys. You need to respect the liver. You need to respect the labs, right? Because clinical precision doesn't just improve therapy, it is protecting the real lives. Okay. So that is the end of the session today. I hope it is fruitful for you and it is making sense. It is not about only the dose adjustment and dose calculation, guys. Okay. It is about what to do next. Okay. How to handle these cases in real life. Very, very important. Okay. So, any questions from your side? Just give me a minute. I will be back. Just a minute. Okay, I can see some questions. Okay, the answer was 31.25, the formula. I will recheck. I will recheck. Don't worry. Everyone is getting that answer. Okay. See, that is not about formula, guys. Formula is very simple and you can use it on a daily basis. Don't worry. But after things are very important. Okay. One question I can see, how can we adjust the time and how will we know which will be appropriate? Okay, so how can we adjust intervals? I think that is what your answer is. We adjust the time, which is dosing intervals, when the drug stays longer in the body due to some reduced renal and hepatic clearance, right, to prevent the drug accumulation and toxicity. So how do we adjust? Now, if the drug is, you need to check here that if your drug is time dependent, like most of the antibiotics are time dependent, so you will keep the dose same and increase the intervals. And if your renal function is reduced, like low creatinine clearance is, seen, you will lower your creatinine clearance for the for after long interval increasing, so you will increase your interval time to lower your creatinine clearance. So if drug accumulation causes toxicity, you will extend the interval. And how do we choose the interval? So you will follow the drug dosing guidelines. We have drug dosing guidelines based on creatinine clearance, and for hepat we have for child pug as well drug dosing guidelines. Also, you will consider the drug's own half-life. So if longer half-life will be there, longer interval will be needed. So it is depend on what drug you have aim in mind. And you will also use some therapeutic drug monitoring whenever it's available. So yeah, this is how, you can extend intervals to prevent accumulation. Yeah. So this is how you can decide. I hope it is clear to you. What if the patient undergoes a dialysis? We need to follow the same criteria for them. It is a very good question. See, dialysis patients are a special category, right? And the answer is no. We do not follow the same criteria as a non-dialysis CKD patients is having different. So yeah, answer is no, because dialysis itself removes the drug from the body, right? So dosing depends completely on the type of dialysis patient is having, and whether the drug is dialysable or no. That is also one of the thing to remember in dialysis patient. Okay, I have my thesis on CKD, so yeah, that is why yeah, dialysis was our topic for in a fifth year, back in fifth year. So I know that type of the dialysis and whether the drug is dialysable, that you need to check. So key rule is there in this scenario. If in dialysis patient, uh, we actually dose according to dialysis clearance. We adjust the dose according to dialyzing clearance, okay, not the kidney clearance basically. So criteria will be different. And let me tell you also what decide dosing in dialysis patient. So we need to check the drug molecular size, protein binding, volume of distribution here, water solubility. So this decide whether the drug is removed by the dialysis or not. So of course that is how we can practically have approach. So in dialysis, this creatinine clearance, if you are calculating, that becomes unreliable, right? Dialysis timing becomes very crucial, and pharmacists, must coordinate like in these things. We were doing it, right? So these are important things. Then how do we? What is this? I think you have continuous question, right? In this, let me check. You have continuous question? Yes. So how do we maintain what frequency? What about loading dose for them? For dialysis patient, are you asking? While undergoing dialysis, can we? Yes, okay. So this is again another rule is there. Okay, how to maintain frequency in dialysis and this type of patient. So basically, what maintaining dose and frequency, it is depend on drug removal by dialysis and CRRT. Okay, so we always ask like, is the drug removed by dialysis, and how intensive is your this continuous clearances, right? So what happens? Type of the dialysis matters, I told you. So in intermittent dialysis, let me discuss intermittent hemodialysis. We have IHD, which is very common. If the drug is dialysable, your dose, this is very common with after dialysis, right? So if drug is dialysable, you will do after dialysis. If frequency is usually longer, like 24 hour, 48 hours, this IHD is very common with, frequency is very longer in that situation. And in CRRT, of course, CRRT runs continuously. So drug is removed continuously. So frequency often becomes similar to normal renal function, right? But yeah, that dose may be slightly reduced. So yeah, CRRT is not equal to ESRD dosing, and CRRT behaves more like moderate renal function, right? And the another question is about loading dose. That is again very important concept. So loading dose is, not based on the renal function. Let me tell you why. Because loading dose is, guys, completely depend on volume of distribution and what exactly you desired plasma concentration, what exactly you need to maintain in a plasma concentration. So these two parameters are very important when it comes to loading dose, right? So yeah, give full loading dose in this scenario, even in ESRD, even in CRRT. Okay. So that is simple rules you must remember about the loading dose, that it is same as the normal patient, no reduction is there, and it is given to achieve the very best therapeutic level as fast as possible. Okay. So in one line, I can say loading dose is loading dose is same in dialysis and CRRT. Only maintenance dose and frequency are adjusted based on dialysis clearance, right? That is what I can say. So these are loading dose and maintenance dose you can remember for dialysis patient. Dialysis is a complete different scenario to discuss all the time. Okay. Okay. Can we give antibiotic in mid of the dialysis? Usually no. Usually, no. Antibiotics are not given in the middle of dialysis, because dialysis can remove the drug. Of course, that is a simple reason. And drug levels, fall suddenly, subtherapeutic range aa jayega. So yeah, that leads to treatment failure and resistance sometimes. So yeah, that's very important. And those antibiotics which are dialysable, those are also preferred after dialysis, not in between. Okay. I hope it is clear to you. Yes. Okay. Simple things are there, but dialysis is a complete different profile. How to calculate eGFR? Okay. eGFR is the estimated glomerular filtration rate, and it is usually, do not calculate it manually in practice. You are not doing it manually. It is automatically reported by the lab using some standard equation. So don't worry. Okay. Just a minute. I'm checking that in between. Someone is asking me in personal chat the questions. Can you please elaborate your question in this general chat, guys, so I can read it? Okay, so I can see one more. You said that healthcare professionals are considering CKD stages based on EGFR, ma'am. Is it true? Yeah, that is absolutely true. Let me clarify. See, CKD staging is based on EGFR. If your EGFR falls under particular range, you can, CKD stage grade 1, 2, 3, A, 3B, you can classify. 3A and B is also available, guys, nowadays in a, recent guidelines. So yes, CKD staging is based on EGFR. However, I can say it for drug dose adjustment, you need to calculate creatinine clearance. That is preferred because most of the dosing recommendations are based on creatinine clearance and not EGFR. But for staging, of course, you need EGFR. Last question. Okay, no worries. You can ask as much as you can, as much as you have. Don't worry. I can read it for you. Last question. If antibiotic frequency is, yeah, TDS, if patient undergoes dialysis, how can we administer? Okay, so see, we do not continue TDS dosing as it is, guys. Okay, if it is this scenario, okay, step by step, I can say how you can handle. See, if it is IHD, which is most common, or if it is CRRT, continuous. Okay, so if the patient is on IHD, do not give the TDS. That is what the solution is, because dialysis removes the drug and giving TDS causes wastage or accumulation directly. Correct approach in this scenario is giving the dose after dialysis or reducing the frequency, like usually it is once a day or twice a day depending on the drug. Okay, meropenem is a ultimate example to understand this. If the ESRD situation is there on a hemodialysis, 1 gram once a day after dialysis is the meropenem related dose. You can, meropenem related frequency you can consider. So TDS becomes, once a day post dialysis. I hope it is making sense to you. Yes. Okay, any more questions from your side, guys? I hope you build some clinical skills and judgment skills, I can say, little bit today. Yeah. Which is more important in case of dose adjustment. Do we have a reference book for dose reduction or each drug in accordance to creatinine clearance for actually reducing dose or particular drug use? Yes, we have reference with us. Uh, I will let you know. Okay, we have reference with us. I will see. We have lots of reference, right? So some good option I will let you know. In the group, I will send some soft copies as well because I have in my uh, uh, desktop. So for the dose calculation, I have lots of material, guys. So yeah, I will forward it. Some good I will extract and I will forward. Someone has message on the WhatsApp, I guess. Yeah. Uh, so I will do it. Any more questions from your side? Someone is asking on a WhatsApp, someone is asking in a personal chat. Uh, can you guys please write your message in this general chat box? What about this? Yeah, dose adjustment. Okay, so again, a good question I can consider, because this teicoplanin dosing in CKD, this is very commonly, asked. I can consider. So for that, loading dose of this particular teicoplanin that is not reduced in CKD, maintenance dose, that is adjusted based on creatinine clearance, because this particular drug has a large volume of distribution, and loading dose is needed to achieve therapeutic effect, right? So yeah, renal function mainly affects on the drug clearance later, so this is how you can calculate your loading dose. Completely depend on the clinical scenario, how exactly you want it. Which specific drug level, peak, through, or AUC should we track, and how often should it be checked as we titrate the dose? Okay, so see, it depends on the drug. Okay, it depends on the drug. We don't track the same level of same level for all the drugs. So most commonly used is the middle one. Okay, so this is used for the drugs where toxicity relates to accumulation. It is like directly indicating like vancomycin, digoxin, lithium and all. Okay, so it reflects your drug accumulation just before the next dose. So yeah, just before the fourth dose, like a steady state, you can recheck after you are changing the dose, or you are changing the renal function. You are checking the renal function test. So yeah, that is what the middle one, that is what you can do for the middle check. For the peak level, that is used when the efficacy is, I can say, depends on the high peak concentrations. For an example, aminoglycosides. So why peak? Because to ensure the drug reaches effectively the bactericidal concentration, right? So that is generally, as per my experience, what they check after 30-minute IV infusion of aminoglycosides. They check it, the peak concentration, and usually it is checked once only, and then they are adjusting it. And for area under the curve, I can say that is very preferred one. This is very widely used in case of vancomycin and all. So because of course it can balance the efficacy and safety. So yeah, in early therapy you can check AUC like within 24 and 48 hour, and it requires also some software and two levels on a peak plus through that, both of that is required. So this is how you can check. So, the monitor level is depends on the drug, like what you want for the whole calculation and to dose adjustment. I hope it is making sense to you. It is completely depend on the drug. And you will do practice in the continuous your ward round and all. You know what? You will get some idea also, because it is very much practical things. Okay. Tomorrow onwards also we have a same time, guys. 7:15 we will start. 7:15 to 9, okay, or 8:45. If in sepsis, if fever was not reduced, can we give dose without adjustment for CKDP? No. Clear answer is no. Even in sepsis, we should not give unadjusted maintenance doses in the CKD patients. The answer is no. Okay, sepsis is one of my favorite topic to discuss, guys. यहाँ पे आपको loading dose पहले calculate करना पड़ेगा, and you need to go forward with the correct approach, which is sepsis plus CKD guideline is suggesting. Okay, so in sepsis, a full loading dose can be given even in the CKD, but maintenance dosing must still be adjusted according to renal function. Okay, that is what the answer is. Okay, guys, if you have another questions, feel free to drop message in the WhatsApp. Okay. Okay. Thank you so much for joining today. Thank you. See you guys tomorrow. Thank you. Good night. Thank you.